Good morning. Welcome to this lecture on aging and cognitive function. I am Linda Lam, Professor and Chairman at the Department of Psychiatry of the Chinese University of Hong Kong. I am a psychiatrist by training and I work mainly with older people. So in this talk, we will briefly outline the issue of population aging, not only in Hong Kong but all over the world, as well as the effect of aging on cognitive function. With that, we would hope to introduce you with a life course approach to how we visualize the effect of aging and cognition. In the third point, we would like to say something about prevention and intervention for cognitive decline from a multidisciplinary perspective. Population aging is a worldwide issue nowadays. The fastest rate of growth actually will be from the developing countries. China is one of them. We will note that in the next few years, population age over 65 years and above will actually outnumber that of the younger population. In this graph, you will notice that the Chinese population by age group, we are now around 2014, around here. From this year onwards, the age of older populations, age 65 and above, will be much higher than that of the younger population, age 20 and 24. So this issue is not only in Hong Kong, but also in China and all over the world. In this World Health Organization report, it is noted that the age population will actually double in 30 years. So we will be facing an increasing population with older people walking around. So if you look at our community, you will note that Hong Kong has a very high life expectancy, and actually in this graph, Hong Kong has the second highest life expectancy only after Japan, compared to most developed and developing countries all over the world. From the latest Hong Kong statistics, the life expectancy at birth is about 85 for the woman and almost 80 in the men, and it has been for many years the second highest all over the world. So if you look at these statistics from the Hong Kong government, we will note that now we will have around 13 to 14% of people older than 65 years of age. But in 2041, I mean less than 25 years, the proportion of older population age 65 and above would be about 1/3 of our general population. So just look at this Hong Kong population pyramid. Before the baby boomer stage is 1961, is about half a century ago. We have a large number of young population with potentially high productivity and encouraging workforce. About 10 years before, the pyramid actually shifts up with more mature adults in the middle age range, but that the situation will get even worse in 2033, less than 20 years. So in this is a reverse population pyramid where people much older would occupy a large proportion of the population structure. So what would be the impact of population aging in the society? The first thing, of course, you have been well aware of is the very low population growth rate. With that, it also leads to much reduced productivity. It's not only that, we have a society with an increasing burden of care because older age is associated with a higher prevalence of physical and medical diseases, as well as cognitive decline and physical frailty, and also most of them in the advanced age may have some degree of loss of independent functioning. This issue does not only cut across sectors of medical and health, it also affects our social, financial, and accommodation considerations. If Hong Kong is to be developed into an age-friendly society, there are also issues on transportation and lifestyle considerations for the expanding older population. So if we stop here and to have a question and reflection, perhaps we could think about, and you could think about, what are the concerns of population aging in your area of interest in the next few years. So the next areas that we would touch on briefly is about age and cognition. With that, I hope to introduce you with a life course approach and how to understand disease factors that would lead to age and cognitive decline. In terms of age and cognitive function, we all know that cognitive function actually would decline gradually since early adulthood, as early as the age of 30. But the decline is very gradual and practically not noticeable in the adult age groups. But then older age is associated with faster rate of decline. If we want to broadly define cognitive states in the older age, it could probably be defined into three main categories. The first category is that everybody would want to achieve is what we call successful aging, where an older adult would have very good physical, mental, cognitive, and social functioning. They are surviving very well and fit into old age and even advanced age. But most of us would be undergoing a process of physiological aging, whereas cognitive function would have some decline. But the decline is not usually of the extent that would affect your independent functioning expected for your own age. But there is a group that would be of major concern is what we call dementia. And in the now revised definition of the DSM-5, we termed it as major neurocognitive disorder. So what is major neurocognitive disorder, or similarly dementia? It is a chronic medical condition associated with progressive and global cognitive impairment to the extent that it affects your independent functioning and everyday activities of daily living. The areas of cognitive function that may be affected in major neurocognitive disorder include memory, language, executive function, perceptual motor skills, complex attention, and also social cognition. So if we are taking care of people with dementia or major neurocognitive disorder, you would expect that they would have progressive decline in most of the above 6 areas of cognition. So there are many different types of dementia that you would encounter in both in the institution as well as in the community. But the major types, which accounts for over 90% of the dementia, would include Alzheimer's disease, which is the commonest and the most well-known type. We are also taking care of many people suffering from vascular diseases leading to dementia, which we call vascular neurocognitive disorder. A proportion would also suffer from Lewy body disease and frontotemporal dementia. So the details of different types of dementia would be beyond the scope of this talk, but I would like to let you know that most dementia would lead to progressive cognitive and functional decline. But what are the major risk factors associated with Alzheimer's disease, the most common types of major neurocognitive disorder? Age is one of the most significant contributor. So if you look at this particular graph, we note that the incidence of dementia actually increased exponentially with age, as well as the prevalence. For any studies all over the world, we note that there are approximately 100% increase in the prevalence of dementia for every 5 years after the age of 65. A simple translation is if we have a prevalence of 2.5% at the age of 65, the prevalence of dementia would rise to 5% at the age of 70. So that would have an exponential increase. So if we have an increasing amount of advanced age people, then the prevalence of dementia would be very, very high. So as we have mentioned before, because the developing Asian Pacific countries would have an exponential increase in the aging population, so it is expected that there is a similar rate of exponential projected increase in the population living with dementia in these areas. Because of the increasing population, aging population in Hong Kong, we are expecting also with an projected increase in the population living with dementia in Hong Kong. So this graph roughly shows that we will be having an increasing number of people living with dementia from 2009 to 2039, both in the community as well as in the institution. This graph have a projected increase in the very, very high proportion of people living with dementia may be requiring institutional care in the next 20 years. There are many factors that may affect the development of dementia, which include factors like education, occupation, and your lifestyle. Let us look at this from a life course perspective. What is a life course perspective is we think about diseases and also health states from the very, very earliest stage on. we note that there are genetic risk factors for Alzheimer's disease and other dementia. That means there are hereditary contributions to this disease even at late life. And also we note that education also influences the development of cognitive decline at late life. These are childhood factors and early adulthood factors. How about work and also related factors in the adulthood? What we note is that social activities, intellectual activities, and the commitments at work, and also the complexity of your occupation also influence the risk of developing cognitive decline at late life. How about in the middle age and beyond? Studies suggest that physical exercise, your diet, your intellectual activity participation, your mental health states, as well as your cardiovascular risk also affects development of dementia and cognitive decline decades later when one gets old. So what are these factors? Lifestyles and cognition. We note that better cognitive function in old age is associated with a lifelong higher participation of physical exercise. If you're physically more active and you do more physical exercise from a very early age onwards, committed to adulthood and also late life, it would be a protective factors for cognitive decline. If one is more participating in terms of intellectual active activities throughout life, it is also associated with better cognition. Many people would be interested in what kind of food they take would be more protective to the brain. There are some studies to suggest that diet with high intake of fiber, omega-3 fatty acids, and strong contents of antioxidants may offer some protective effect for brain health years later. How about physical health and cognition? Physical health status, especially in the midlife, is associated with cognitive function at late age. These physical health risk factors are mainly related to cardiovascular risk factors such as hypertension, hyperlipidemia, obesity, and also diabetes. In terms of mental health, we know that people with depression, especially for the chronic depression in the midlife around age 40 or above, is associated with a higher risk of developing cognitive function decline at late age. So both physical health and mental health have strong impacts on cognition. So the second question or reflections here is, among all the factors that we have mentioned, are there any factors that may be modifiable? If these factors are modifiable, that could probably be considered and developed into potential interventions, both from a personal perspective or when you treat patients under your care, or even from a society and community perspective. Not all factors are potentially modifiable, but some of them are. But let's see how we could integrate some of the factors into prevention strategies. Before we think about intervention and prevention strategies, this is a graph that I would like to show you because that would demonstrate the importance of early consideration, assessment, and intervention. This part refers to the late part when a person or a patient develops cognitive decline and dementia. That has been many years of brain degeneration before one really develops memory impairment. Patients usually develop memory impairment at a very late age when there are a lot of significant proportion of brain cells have degenerated. So it could be 10 or 20 years before the onset of memory impairment that one started to have brain degeneration. So if you want to reverse or attenuate the course of decline to a more modest trend, we may not need to cure Alzheimer's disease or dementia, but if we want to slow down decline so that a person would enjoy independent functioning for as long as possible, then we have to start intervention early. So this intervention may have an effect on cognitive function, and that independently would lead to a longer independent life throughout the person's lifespan. So there are many strategies on prevention, but I would like to introduce to you the concepts of primary and secondary as well as tertiary prevention here, and see how the special risk factors that we have considered would be integrated and possibly be integrated into this type of strategy. So we may not be able to change our genetic predisposition, at least for the time being. So this is probably not a major modifiable risk factors. But in terms of primary prevention, we know that higher education attainment, not only at school but beyond school, if one is more interested in continuous education, would be protective of your brain health. So promoting better education in the community, both from a personal and also community perspective, would be a primary prevention strategy. So in terms of occupation, what study shows that if an occupation offers more complex type of intellectual stimulations, that is more helpful. But it has to be done with not much stress. So in terms of occupation environment, having more intellectually stimulating component in a less stressful environment might have an effect on primary prevention of cognitive decline at late age. And how about lifestyle? We know that cognitive stimulating activities and also physical exercise, especially some types of more strenuous type of physical exercise, continuous throughout life would be important for your physical and also brain health. So there should be strategies to strengthen healthy lifestyle, as not only for leisure but also for your health considerations. So these could be considered as primary prevention strategies for dementia and cognitive decline. How about secondary prevention? The most important component of secondary prevention is early detection and early intervention to detect the disease early, especially when before the symptoms start, so that the disease could be prevented from further development and having impacts on a person's health. So we know that cerebral vascular diseases like hypertension, diabetes that we have mentioned in midlife would have a strong influence on development of dementia at late age. So a person should be taking care of his or her health in terms of cardiovascular diseases very early on. For healthcare professionals, there is a role for us to offer better health advice to people, especially on cardiovascular risk. If we are talking about cognitive health. So people should know that taking care of their hypertension, diabetes is not only for the physical bodily health, but also for their brain health in the decades to come. So these are simple and straightforward health advice that we should be bear in mind very cautiously. And people would also ask us on health advice, what things we should do apart from taking drugs that may help to prevent the development of dementia. So that would include physical exercise and intellectual activities. So when should we start physical exercise and intellectual activities? It should be as early as possible. But some people whom you encounter are already in the older age will say it is too late to start physical exercise, or I have never read a book, so and I'm illiterate, I'm not able to read, how can I start having intellectual activities? So this is perhaps there's something that we should consider. Actually, there are empirical evidence to suggest that physical exercise, even performed at late age or even started at late age, would have an impact on physical health and also mental health as well as brain health. So it's never too late to start physical exercise, but if you give advice on physical exercise, we probably need to give advice based on empirical evidence. So just simple stretching, walking around in a leisurely way, or some strolling around than most of our elder people do may not be as beneficial to their brain health as what they expected. So we should read more about the updated literature and what form of physical exercise, such as aerobic exercise or some form of exercise like Tai Chi. They may have special brain stimulation. They may have influence on your cognition. So also for intellectual activities, even for people who could not read or write, or they have limited education attainment when they are young, starting any form of intellectual activities that help them to stimulate their brain would be helpful as well. So these are secondary prevention because we want to prevent the dementia or major neurocognitive disorder from being manifest. But how about if we encounter patients who have already developed dementia? They come to seek help from you because they have cognitive decline. So that would fall into the category of tertiary prevention. So tertiary prevention is when the disease has already developed or manifest. We want to minimize the impact of the disease to that particular person. For cognitive impairment, so there are some medication and adjuvant interventions that help to optimize cognition as well as other symptoms if the disease has already developed. So early treatment would help to optimize their cognitive function. So we do not only take care of medication, because there are many adjuvant interventions such as psychosocial treatment, management for caregiver, helping caregivers to know about the disease and release their burden, as well as special training to enhance and optimize their occupational functioning, which we refer to as independent everyday activity living. So these are very important adjuvant interventions. So there are developments of interventions such as computer-based cognitive training. So these different forms of interventions would help to join together to reduce the impact of dementia on a particular individual. So in summary, if we want to think about the strategies for intervention of cognitive decline in old age, perhaps the first thing that we should think about is for any form of intervention, it should start as early as possible. So early detection of possible decline, especially for the significant decline that may suggest the development of major neurocognitive disorder, is important. So some of the primary and secondary prevention strategies should start very early in life. And also it requires care and attention from different disciplines and different perspectives. We do not only think about mental health and cognitive health. If we want to help people with cognitive impairment at late age, we need to take care of their physical health as well as their lifestyles, because in terms of cognitive function, it has impact on a person's activities of daily living. So the lifestyle intervention, everything would have an impact on the patient's quality of life, not only for the cognition. So this is a multidisciplinary approach and perspective. No single discipline would be able to handle everything in this very important problem of aging and cognition. No matter whether one is working in the health professional area or whether one is working in the industrial area or building areas, this would have impact on our considerations. If we want to build an age-friendly society with good health care, as well as to enable people, older adults with different impairments, to live happily in the community. So my last reflection or questions is probably we could think of one area in your discipline that may help to optimize cognitive function, or from a broader perspective, the quality of life with those older adults who are living with cognitive impairment in the community. So with that, I would like to end here. So thank you very much for your attention.